Dear colleagues, this is an interesting case of phimosis. You saw the first eye, which was operated a week prior, and now the second left eye. Notice the fact that the eyelids are not opening very well, are barely open, so I can get the instruments almost 160 degrees away from each other, injecting the viscoelastic and do the capsulorhexis. I prefer to, in these challenging cases, to do large capsulorhexis, so this one is probably 6 millimeters or so. Will make the phacoemulsification easier in a very challenging case. It's not a big deal. The cataract probably is 2.5, 2 plus or 3 grade, but the access to the eye is very challenging. The eyelids, and I didn't want to do a cantotomy, so I cannot have the recovery time post-op prolonged to have stitches and all that stuff. So I almost have instruments like 160 degrees away from each other, which is not a big deal. So you can manage all kind of cases. I do a stop and chop technique here. Notice the fact that the patient also have a dry eye. The cornea is getting dry very fast, so we have to put a lot of BSS on top of it, and often, very often. The crack, it's a partial crack here, but insisting you can go deeper and deeper, and I eventually got all the way down to the posterior plate. You can see the posterior capsule. I'm trying to do one heminucleus up, and the irrigation, it's pushing the other half out of the bag, and I usually take the gift in. Very glad, especially when that it's coming in the middle of the surgery. I'm very happy to take advantage of that gift that the irrigation gave me, and have the half of the nucleus out of the bag, doing more chops and getting the nucleus into smaller and smaller pieces, which are very easy to emulsify and get it aspirated out of the eye safely. You have in these eyes, usually the axis is pretty much on an upper nasal quadrant and temporary. When you have the eyelids that I cannot open very widely, and half of the nucleus is out, moving the other half inside the bag, and it's very easy to have that out also, and get that into smaller chops and easily getting emulsified. Slowly but steadily you can manage all kind of cases, and at the end is just epinucleus left over, which is easily aspirated, and cleaning up the bag, injecting the IOL and all that is not a big deal. I'm not going to waste your time with all the steps, but as you can see, even in these challenging cases, you can have a nice outcome if you get if you are patient and slowly do the steps of the surgery, which are already a routine. In every case, if you apply the routine parts of the phaco emulsification, even these challenging cases where the board it's kind of difficult, you can manage very easily. So cleaning up, injecting the IOL, injecting some myocola at the end of the case, and that's about it. Thank you for your attention. Hope this will help you in your practice also.